here. Hopefully all good now. So now we're recording, and welcome everybody to today's Tuesday topic, Adventures in Pacing. So I am going to be talking about some errors with pacemaker therapy in a particular patient. I'm going to start off with some discussion about this patient. So this is the first pass. By the way, the nurse who was seeing this patient in the emergency department documented beautifully. She wrote 32 little notes, and they were all about what was happening at the bedside. So it was really quite easy to see what was happening, but I'm choosing to share with you the residence and the cardiology note because it really makes a lot of sense when we take a look at this patient. So this is an unknown aged male brought in by emergency services after having a cardiac arrest following a full session of dialysis. So at the dialysis center, the patient lost his pulses, had a full cardiac arrest. CPR was begun on the scene. That means he had bystander CPR. He was in a medical facility. He was defibrillated ×1. He received epi ×1, bicarb ×1, and calcium ×1. But I would tell you that that was probably from EMS, not from the dialysis center. So they initiated CPR, EMS arrives, they defibrillate, they give epi, they give bicarb, they give calcium, and ultimately the patient has a return of spontaneous circulation. But then he has VT again with loss with pulse. He didn't lose his pulse ×3. Okay, so they used basically an LMA, and they ventilated via bag valve mask by EMS because they could not intubate because the patient's jaws were clenched. So these are all really important clues as to what's going on with this patient. They gave IOs to his left tibia and his right humerus so that they could administer medication. And cardiac rhythm on arrival to the ED was VTAC with pulses present. Okay. So in the ED, he's intubated, first attempt. He gets IV access, bilateral EJs and a right femoral central line, right femoral arterial line, all placed emergently, which means basically not sterilely. And he's stabilized after he receives IV lidocaine, amiodarone, bolus, and drip, and briefly an esmolol drip. Code ICE is activated, which means he's going to receive TTM. Now, he's a patient, actually, who had a cardiac arrest with immediate bystander CPR. So at our hospital, that means he qualifies for 37 degrees. But he's admitted to the CVICU, and he is placed into full TTM at 33 degrees for post-cardiac arrest care. Interventional cardiology and electrophysiology are consulted because the resident recognizes, very good, maybe saw some history, not anything that I could see on the patient, nothing that I could access in an old chart, but the patient does actually have a pacemaker, and it's a permanent pacemaker. And the concern is that the pacemaker may be malfunctioning and the patient may have VT storm. Very, very less likely to be an acute coronary syndrome, much more likely from the resident's perspective to be VT caused by a malfiring pacemaker. So I want to take a look at my patient, our patient's first EKG, and I want to also take a look at the patient's evaluation lab. So on first pass, what we're seeing here is we're seeing that we have a patient who has an irregular rhythm. Now, remember, whenever you have an irregular rhythm, the expectation is that that is not VT. Also, when you take a look at this, what you have is what we call negative concordance. Now, VT typically means that all direction of your primary R or your QRS is always pointing in the same direction, and you can see, indeed, that is not true here, okay? This actually looks like a pacemaker malfire, or possibly AFib. But regardless, he's got pulses, so he gets, I assume, even though they wrote defib, I'm assuming that he was cardioverted, not defibrillated, because they wanted to get him out of this rhythm. They bolus him with amiodarone, et cetera, all great. But I want to also take a look over here. Now, here's a patient with chronic end-stage renal disease, chronic renal failure, who requires 3 times a week dialysis. And when we look at him, we see that his admitting potassium is 3.1. So everybody who knows me knows that I remind you that cardiac patients with renal disease or otherwise should never have a potassium of less than 4. So what we have to assume is that he was aggressively dialyzed and we caused some electrolyte instability, which may also have contributed to his ventricular dysrhythmia. Trying to figure out what's going on here. Is this just wide QRS tachycardia? Is it VTach? But I would like to let you know, not that I always think computer interpretation is correct, but the computer interpretation, the computer didn't want to commit. Computer said wide irregular tachycardia, which typically means this is not VTach. So taking a VTach stance here didn't hurt the patient unless he was actually defibrillated. That indeed could have harmed the patient. So when we see that you are irregular and in the chest leads, so that would be V1, V2, V3, V4, V5, V6, when we don't have concordance, meaning all the points go in the same direction, this is called negative concordance. That actually makes us think that it could be Brugada syndrome, that it could be atrial fib or some other atrial, like atrial flutter, atrial abnormality with wide QRS tachycardia. So very important to remember, here comes a patient, you don't know anything about him. You don't really see that he has pacing spikes. I'm sure that they found some old chart that told them that, or actually the initial medical resident note was written after the cardiology note. So cardiology says, okay, I've been seeing this patient who has a cardiac arrest. He has end-stage renal disease, congestive heart failure, and he has recently received a permanent dual chamber pacemaker for symptomatic bradycardia. For bradycardia, okay, not for VTach. And it's a rate-regulated pacemaker. Now, how that's going to be entitled when you look at a chart or when you look at a pacemaker evaluation. Now, remember, this is a permanent pacer, so there's nothing we can do to manipulate. We have to use a magnet. We need to call cardiology. They can come and reprogram. He might have to go to the EP lab to be reprogrammed. There's nothing we can do about his pacemaker. But in the original note, it took a long time to find it, and thanks to my CVICU colleagues, the original note said that he had a DDR. That means dual chamber paced, dual chamber sensed, rate regulation, meaning that it's firing when the heart rate goes below a certain level. Okay, so really, really important. So now the cardiologist lends a little more light on the patient. He says, oh, the patient was at dialysis. He's sustained VT, required shocks, appears to have had another episode of VF. And then they applied, of course, ACLS, and he had return of spontaneous circulation. Okay, intubation for airway protection, recurrent VT in the ED. On EKG, it's seen that there is failure to capture and failure to sense, which means you have pacemaker failure. You're not sensing, you're not capturing, you have pacemaker failure. So electrophysiology emergently is called to the bedside. They do an echo, and they see that the lead is in the apex of the RV. That's where it should be, okay? There's no effusion, but he has a terrible left ventricular ejection fraction, less than 12%. And the RV is very dilated with reduced function. Chest x-ray shows that the RA and RV leads are in place, but they're not sure if there was some perforation in the muscle wall. They couldn't actually exclude that. Now, remember, sometimes when your electrolytes are abnormal, if you have edema at the site, you actually will not be able to pace your patient appropriately. So that's also partially or possibly what happened. Okay. So he's got a known non-ischemic etiology for his heart failure. And the belief of the cardiology resident is that VT is related to congestive heart failure and possibly electrolyte abnormalities. Now, that's really important. Related congestive failure and possible electrolyte abnormalities. The troponin level is elevated, but they think it's probably type 2. They don't really think he's had an acute myocardial infarction, but they had to reprogram his pacemaker. So this was all done down in the ED. From DDR, dual chamber pace, dual chamber sense, rate regulation, to VVI, ventricle paced, ventricle sensed, and inhibited, meaning when you sense a ventricular beat, the pacemaker will inhibit further firing. So this was really, really important. And they also increased the MA, the milliamplitude, to try to capture the heart. So this is all very important. He's on aggressive suppressors. He's on amiodarone. He gets admitted to the CVICU. They start TTM. And the discussion overall is, yeah, we really need to manipulate his pacemaker. But it appears that he has some possible to probable neurologic deficit secondary to his downtime. So we're going to wait till he's out of TTM. And if he wakes up, we'll take him and upgrade the device and reprogram the device in the electrophysiology lab. We're not going to do it at the bedside. Can't really do what needs to be done at the bedside. Don't want to take him to the cath lab to go to the EP lab with his instability. And also if his neurologic function is not going to improve from where he is when he gets admitted to CVICU. So he has, he has multiple comorbidities, a really significant issue, and a cardiac arrest. I believe when we look at this, he had a cardiac arrest. I don't know if he had VT. I don't know if he had torsade. That's my likely perspective, is that he probably had torsade de pointe, which we're going to review kind of quickly here. And we're also that he had very severe electrolyte imbalance, because in the dialysis unit, when you go to a off-site dialysis center, they want to turn patients over really quickly, and they do their therapy quite rapidly. So they're flowing really rapidly, they're pulling fluids really rapidly, they're clearing electrolytes really rapidly, and you often can have some disequilibrium in your electrolyte balancing, which is something else that we have to consider with this patient, especially as it relates to the fact that he has poor neurologic evaluation, but has not had neurologic or cognitive deficit before. And he had CPR at the site with medical trained bystanders. So why is it that he's neurologically disintact? That's really the question. And my concern would be that this is actually related to disequilibrium. So we can't know that in retrospect, but we can see that his potassium was 3.1. So let's just go back and look at some of the other labs that were done at this time. Okay, so his potassium is 3.1. His lactic acid is 3.4. His BNP is over 2,000, no big surprise. And point of care troponin was 90 and then 94. Okay, all right, so second pass from the resident. Now the resident actually explores this much more significantly. And he says, okay, he was shocked at 200 joules, which probably was more on the side of cardioversion, although remember, cardioversion typically is going to be about 100 to start, and then you move to 150, and then you can move to 200. His blood glucose was 144, so that wasn't the problem. They did do some compressions because he didn't have a pulse. He got epi, has a pulse. Pupils are 3 millimeters and fixed, and he's clenching his jaw. So they have to give him a paralytic in order to intubate him. And once they did that, it was easy to intubate, but he was also very hypotensive with a MAP close to 65. So the decision is, let's get started on norepinephrine. He got rocuronium, he gagged during intubation, he went back into what they called VTAC, we don't know, shortly after intubation, but now they say, oh, we cardioverted him with 200. Perfect. Whether it's VTAC or wide QRS tachycardia, cardioversion is the right thing, and starting amiodarone. But remember, in a heart patient, amiodarone is not effective when your potassium is already so low. Okay, so that's really, really important. He probably got potassium supplementation, but I didn't see it documented anywhere. He goes on fentanyl, he goes on propofol, bedside ultrasound doesn't reveal any hypokinesis, and EKG does not reveal ST segment evaluation, but it does reveal that his pacemaker is failing to sense and capture. Okay. Now, lots of times people say, oh, the pacemaker is failing to sense and capture, when in reality, it might not be that at all. That's pretty sophisticated. We need an electrophysiologist to look at that EKG and to also know how that pacemaker is supposed to operate. Okay. How that pacemaker is supposed to be operating. Okay, so that's kind of giving you this basic history. And then I just want to talk a little bit about pacing. I want to talk a little bit about pacing, and I mean a little bit, because pacemaker therapy and intervention and evaluation is a really long talk. But I just want to remind you that most of the time, most of us are used to looking at single chamber systems. That means there's one electrode either in the atrium or in the ventricle, not in both. That's a dual chamber system. What he has is a dual chamber system. Okay. So lots of times we're going to use atrial pacemaking for patients who have chronic AFib. We may use ventricular pacemaking because we have AV nodal dysfunction or sinus nodal dysfunction. The problem is that when you are just pacing your ventricles, so right here you see, here's your pacing spike, here's your patient's own beat, here's your pacing spike. The spike is followed immediately by the chamber response, and this is a ventricular pacemaker. The wires in the right ventricle in the apex fire an amplitude, it captures the heart. When you're capturing the heart, your response, whether it's atrial or ventricular, must follow immediately after the pacing spike. You can't have any delay. If you have a delay, that's a failure to capture. It has to follow immediately. So here you can see you've got good spike capture, good spike capture. And then we look over here, this is your atrial spike, but normally with atrial pacing, normally you can't really see the P wave. So that's a hardship for us, because we can always find a lead where we can see a ventricular spike and ventricular capture. We can't always find a lead where we're looking at atrial spike and atrial capture. We might see the spike, but we typically don't see the capture. So here's the thing I want to talk about when you talk about atrial pacing. When you atrially pace, a lot of times you won't be able to see the P wave, but you should, if you have an A-line, you should always be monitoring stroke volume. If you're pacing your atria appropriately, the atria will contract and squeeze blood down into the ventricle, and that will profoundly affect your stroke volume. It could be up to 30% of ventricular filling. So then if I stop my atrial pacemaker, because I'm trying to figure out, am I actually pacing the atria, what I'm going to see is the stroke volume is going to drop precipitously. Well, that tells me that I was capturing the atria. Can't make that decision all the time electrically, because I can't always see a P wave in response to electrical stimulation of the atria. Now he has a dual chamber system. So there's a lead that's implanted in the right atria and another lead that's implanted in the right ventricle. And when we go back and review what the chart says, it says that looking at the X-ray, it shows that the lead is in the right atrial wall and the other lead is in the apex of the right ventricle. Can't evaluate microperforation, but we don't have a big perforation. If we had a big perforation, we'd have a cardiac tamponade. So you might have some small perforations. You may also have some edema, and you may also have electrolyte abnormalities. Well, we already know patient has edema. You saw what his BNP was, 2200. We also know that he had electrolyte imbalance. We saw what his potassium was, and we should always assume when your potassium is low, your mag is low, your calcium is low, and your phosphorus is low. So, you know, those things happen when we aggressively dialyze patients. So on the one hand, we're trying to save his life, and a fantastic job was done by all to save his life. But on the other hand, we're trying to prevent him from having further cardiac arrest, further abnormalities, and we have to think about an electrolyte profile that we're going to do some restoration. As soon as we get that electrolyte balance back and we see that potassium is low, if we didn't do a MAG, if we didn't look at ionized calcium, although we did on this patient, and we didn't look at phosphorus, which we didn't look at on this patient, we should assume that all his electrolytes are low and do some minor electrolyte replacement. I'm probably not going to want to replace calcium unless I'm certain that his calcium is low. Okay, so dual chamber, I have a spike to the atria and a spike to the ventricle. Now here we're very lucky. We see spike followed by P wave. That's really extraordinary. And then a spike followed by the QRS. Okay, so this is spike atria, spike ventricle, spike atria, spike ventricle, spike atria, spike ventricle. You're firing at an equal rate. The spike to spike interval of the atria equals the spike to spike interval of the ventricle, and the response is in a timely manner. This is a beautiful strip. This gives us AV synchrony. It means our atria contracts and fills our ventricle. I myself would never want this. This is a very narrow interval. This is only like 2.5 boxes. So that means the interval between atrial contraction and ventricular contraction is less than 0.12 seconds. For me, with anybody who's got heart failure, I want that interval. So I want from atrial spike to ventricular spike to be about 0.20 to allow time for the atria to contract and fill the ventricle. Okay, so remember, I can manipulate that when it's a temporary pacemaker. Lots of times I'll talk to the surgeon. I'll say, I think we need a longer AV interval. The surgeon says, do whatever you want. And I say to the nurse, this is what I'd like to do. I say to the APP, this is what I'd like to do. Everybody come in the room. Here's where I'm doing it. I'm prolonging the AV interval. And the last time I did it, which was last week, in a CTS patient, their stroke volume went up by about 12 cc's and their cardiac output increased by 0.5 liter. So really, really important for us to appreciate that. But remember, this patient has a permanent pacemaker. We can't manipulate that. EP has to manipulate it. Any manipulation, just evaluation is going to be done with a magnet, but manipulation is going to have to be done in the EP lab. Okay. So again, we talk about a dual chamber pacemaker, that you have a lead in the right atria, a lead in the right ventricle. Now, this is not the same as an AV sequential pacemaker in a post-op patient who has leads on the outside of the atria and the outside of the ventricle. So directly on the muscle wall, because we've opened the chest, we put the leads on the chamber. With a permanent pacemaker, the leads are in the chamber. Okay, so AV sequential pacer comes back from CTS, had an open heart, so we put the leads on the external surface. But someone who has a permanent pacemaker or a temporary pacemaker, not AV sequential, which requires that we opened your chest, has the lead inside the chamber. So here you see the lead in the atria and the lead in the ventricle, and then we look at it over here. And it's a little bit hard to see. Here's that lead in the atria and the lead in the apex of the right ventricle. And here is the embedded internal pacemaker generator. Okay. So I want to remind you about the code. It's the same code everywhere in the world. There are 4 pieces of information here. Okay. So paced, sensed, response to sense, controlling the rate, or doing multi-site pacing. Okay, so most of the time, we only talk about these 4. And for the majority of us, we only talk about these 3. Okay, so normally when we're talking about pacer, we talk about who was paced, who was sensed, and what was the response to sensing. So response to sensing typically means that if the atria is sensed, then you will trigger a ventricular spike at a programmed interval. Basically would be a PR interval, or what we would call the AV interval. And also inhibited, meaning that if I've sensed that the chamber has depolarized on its own, I'm going to inhibit my pacemaker fire. So D means dual chamber paced, D means dual chamber sensed, D, which is what this patient had, dual function, inhibited and triggered, and R, that we're modulating the rate, that we're actually going to fire to increase his rate because he has symptomatic bradycardia. So what he had was a DDDR. That's what he came in with. The concern was that the pacemaker leads weren't operating well, that the battery may be failing in his pacemaker, that he's got pacemaker malfunction. So very quickly, they switch from the DDDR to VVI, meaning that only the ventricle is going to be paced, only the ventricle is going to be sensed, and if the generator senses that the ventricle has its own depolarization, not from my pacing wire, it will inhibit and reset the cadence of the pacemaker spike, VVI. So in the ED, he goes from DDDR to VVI. He gets admitted to the CVICU with a VVI pacemaker. Okay. Now, there's also triple chamber sensors. That's most often called cardiac resynchronization, because we put a wire in the right ventricle and the left ventricle, so they both are depolarized and contracting basically at the same time. It's a fantastic way to pace. Typically, we only do cardiac resynchronization therapy for YQRS, YQT, or somebody who is in class 3 to class 4 heart failure. That is not what he has. He has a dual chamber, not a triple chamber. Okay. And when we talk about this, we call it biventricular or CRT, cardiac resynchronization therapy. Now, if you're interested in heart failure, you listen to talks about heart failure, you will often hear people talk about CRT. CRT is cardiac resynchronization. So just imagine with me. So this is my right hand. So it's to your left, but it's my right hand. My pacing wire is in the right ventricle. So the right ventricle is stimulated and it contracts. And the impulse is spread through the wall to the left ventricle, which contracts later. So the way my heart normally works, right, left, right, left, right, left, almost right at the same time. But with an RV wire, it's right and then left. And it's like a left bundle branch block. So it's a dysynchronous contraction of the ventricle. Well, if you have heart failure, when you have severe heart failure, you can't tolerate dysynchronous contraction. So the idea might be for this patient, if he wakes up, he goes to the EP lab, they may do, and they probably will, cardiac resynchronization because he's in heart failure. He's got a very poor EF to try to synchronize right and left. So they are basically at the same time instead of what they're doing right now, which is right, then left, right, then left. You and I are almost at the same time. It's like such a tiny difference. And that's what gives us the best possible blood flow forward and the best ejection fraction and the best cardiac function in order to survive. So from my point of view, if this patient wakes up, I'm pretty certain they're going to consider, because they've got to manipulate the pacemaker. It's old, it's got some problems. He has problems with his pacemaker. They may actually determine that they want to give him a triple chamber system, one lead in the right atria, one in the right ventricle, and one in the left ventricle. Now, right atrium, right ventricle is placed right through the IJ, but you can't get to the left ventricle from the IJ because that's venous. So you actually have to go into the coronary sinus, into the coronary sinus vein, so at the cusp of the aorta, and place that lead wire through the coronary sinus vein, not the coronary artery, through the vein, and then embed it into the wall of the left ventricle. This is always something to be thinking about. I think CRT has become a lot more prevalent. We have not done it very much here at Grady, but it is something that I think we're going to need to consider. Okay, now about VTAC. Okay, so everybody here knows VTAC. This is just a nice algorithm, very hard probably for you to see, that just says, when you see a YQRS tachycardia, so that means greater than 0.12, you need to know, is it regular or irregular? If it's regular, the likelihood is you're going to continue down a VT tree. If it's irregular, like our patient, you should really think that it's probably something related to his pacemaker, related to a bundle branch block, AFib, or a flutter. If it's irregular, probably not VT, and you end there. Okay, that's really important. Okay, now I'm not saying anything because they cardioverted him, so fantastic. But actually, I don't think that from his first EKG that I saw, I didn't see the EMS EKG, I only saw the first EKG, which I showed you. From that first EKG that I saw, what I felt was that was irregular, and that did not look like VT to me. Yes, he may have poor pulses because he's firing quite rapidly, and he doesn't have optimized filling because his pacemaker isn't working. So you go down this tree of very regular, meaning from point to point is exactly the same every single time. And then you look at the width of that QRS and you confirm whether or not the patient has VT. Okay, so really, really important. And really looking at AV relationship. In addition to that, just to remember that 3 or more beats of ventricular depolarization in a row is considered VTAC, has to be greater than 100 and is typically less than 180. If it does not sustain for greater than 30 seconds, that would be called non-sustained. If it sustains greater than 30 seconds, even if it spontaneously resolves at 38 seconds, that is called sustained VT. And we're going to treat them a little bit differently. We're going to be a lot more aggressive with sustained VT. We have a little more time with non-sustained VT. Okay, the next thing that we always have to consider when we're looking at VT is it from one impulse or is it from multiple impulses, which means that it looks the same from beat to beat to beat, or it's continuously changing in its QRS morphology. Sinusoidal means that it almost looks square. And the other thing is this an idioventricular rhythm, meaning it's wide and it's fast? And that's something we always have to consider, an accelerated idioventricular rhythm. Typically, accelerated idioventricular rhythm is wide, looks like VTAC, but the rate is typically less than 120, okay? So these are really important concepts when we're evaluating VTAC. Okay, so monomorphic VT, which he does not have, he has polymorphic VT, or if he has VT at all, it would be polymorphic. But typically you see monomorphic VT with patients who have had an MI, and this actually is a circuitry that occurs with the dead tissue or old myocardial infarction. Sometimes you just have VT with no known cause, sometimes because you have obstruction to outflow from the right ventricle, like you have a pulmonary embolism, or you may have profound pulmonary hypertension. But what monomorphic VT always looks like, and that's what it looks like for him, on some of his EKGs, it looks like he has a left bundle branch block morphology. Okay, so let's take a look at this. You can see that in each lead, 1, 2, and 3, AVR, AVL, AVF, 2, 3, 1, 2, and 3, and 4, 5, and 6 of the V leads. In that lead, everything looks exactly the same. Everything looks exactly the same. So always looks the same in lead 1, always looks the same in lead 2. Lead 2 and lead 1 don't have to be the same. And by the way, look at your points. Everything is pointing upwards. This is called positive concordance, and this actually makes us think VT. This is not our patient. Then we think about polymorphic VT. Polymorphic VT, very commonly seen with electrolyte disturbances. Based on what they did in the ECC, how they treated him, I believe they felt like he had polymorphic VT. Polymorphic VT can end up with torsade de point, okay? So look at how your points are twisting. They get bigger, smaller, bigger, smaller. They don't necessarily always point in opposite directions, but they get bigger and smaller, bigger and smaller. This is very common with profound electrolyte disturbance. And let's remember that our patient got a pacemaker because he had symptomatic bradycardia, which meant he had some nodal dysfunction. That lends itself towards torsade du point. So also just to remember, you can see the sinusoidal VT that's most commonly seen in electrolyte abnormalities. Hypomagnesemia is one, typically not hypokalemia, usually hyperkalemia, or accelerated idioventricular. Remember I said at a rate of less than 120. You're looking at it, you're saying, oh, that looks like VT, but your patient has a pulse, he's hemodynamically stable, he's probably awake. Very common, very, very, very common to see this with bradycardia. So your sinus node is slowing down in terms of its firing, and this is an escape rhythm that escapes basically from hypoperfusion. So always want to consider the possibility of accelerated IVR. Okay, so very significant. Monomorphic VT almost always related to one single irritable focus. Polymorphic VT means multiple focuses that are abnormal, that are unsustained, that have electrolyte imbalance, that have oxygen deprivation, that have edema. That presents itself as polymorphic VT. So, by the way, all wide QRS tachycardia is considered VT until proven otherwise. So always act like it's VT, except if it's irregular. If it's irregular, assume it's a wide QRS supraventricular. Could be AFib, could be a flutter, could be atrial tach, could be junctional tach. It's above the ventricle and it's irregular, okay? Always look for AV dissociation. That means you have P waves, but they're not connected to the QRS complex. Always look for concordance. So concordance means that you actually see either you're present or you're not. So presence of the RS complex in the precordial leads is positive concordance. Absence of that is negative concordance. The rate has to be a grade, the RS, which is the width, has to be greater than 100 milliseconds. So that's 2 boxes. And then there's some other things that happen, and we're going to take a look at those in just a minute. Okay. So here's what we call a captured beat. That's a normal ventricular response. Here is a fusion beat, this is actually with the pacemaker. So I have a captured beat with my pacemaker fire. I have a fusion beat where the pacemaker spike and the patient's response fuse together. And here you're seeing P waves that are kind of marching through there, but are completely dissociated from the ventricular beats. Okay, so my purpose today is not to explain Brugada. Brugada is a really important concept. We actually see it a lot. It's a particular concept that talks about SVT that oftentimes can be mistaken for VTAC. Okay, so if you have the absence of concordance, the absence of RS complex in all precordial leads. So I hate the way that says it. So if you have that they're all the same, we think that's VT. If they're not, we're going to look at the R to S interval, that RS interval greater than 100 milliseconds. If the answer is yes, that's VT. AV dissociation, yes, that's VT. Morphology criteria for VT, meaning that you have wide QRS, all the same direction. Yes, that's VT. No, so no, 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 and no SVT. Now, I've talked about Brugada before. I just wanted to remind you about it. I'm happy to talk about it again. I'm skipping through that because I want to get to the differential diagnosis here. We take a look at our patient CKG, and what we've got to recognize, expect, and accept that differential diagnosis for him is that he has ventricular paced rhythm, and it looks like VTAC. It also looks like bundle branch block, but it also looks like it's ventricular paced. So all those things have to be in our mind as we're intervening and we're starting therapy. We're going to start amiodarone. We get the chemistry back as potassium is 3.1. Right away, he's got to get potassium replacement. Amiodarone is really not functional in a hypokalemic state. So those are really important. Patients typically will present with chest pain, lightheadedness, other kinds of things. And hopefully you present with all of this and not with this. But what our patient presented with was sudden cardiac death. He had a cardiac arrest. Okay. Therapeutically, we're going to start amiodarone. Everybody is familiar with it. You all are given it all the time. Don't want to give it to patients who have heart block or sinus bradycardia. It's incompatible with normal saline, and we prefer to give it through a central venous catheter. So remember, he got catheterized pretty quickly, got a femoral vein catheterization, and amiodarone began. Got some issues that can occur when you start amiodarone. Patients can become hypotensive. They can have some deposits in their cornea, and that long-term can cause blindness, some skin rashes, and bradycardia. Long-term, biggest concern, that's on people who are on oral amiodarone. So we're giving you IV. We're not really worried about long-term, but if we're going to convert you over to oral, we are going to worry about long-term. Most common problem is pulmonary fibrosis, and the second most common problem is hypothyroidism. So really, really important. And we're just going to think about all those relationships when we start our patient. And then last, but certainly not least, will be an ICD. Okay, so he has not got an ICD. He only has a pacemaker. Okay, so by the way, he will either get a dual chamber pacemaker with a defibrillator, so that'll be a dual chamber ICD, or he will get biventricular cardiac resynchronization with an ICD. Right now, he doesn't have an ICD, but he's going to need one. So that's going to be a really important perspective. The problem is, though, that if his defibrillator fires inappropriately, and they often do fire inappropriately, that is going to make his heart failure worse. So there may be some consideration that he would be better off with biventricular cardiac resynchronization, with rate regulation, but not with defibrillation. Now, about dialysis, a big problem after dialysis is hypokalemia, and that's considered a potassium level of less than 3.5. Now, remember, our patient admits to ECC with a potassium of 3.1. He's lost his total body potassium. He lost that because I believe he was over-dialyzed. You know, dialysis centers are just like the hospital. They're overworked, they're understaffed, they're undertrained. They're dialyzing patients, moving huge amounts of volume. They want you to spend 3 hours or less in the chair. They're really trying to clear you, and they clear you fast. And what often happens when that occurs is what we call dialysis disequilibrium syndrome. So it's really mostly common with first hemodialysis, but the fact that this patient presents to the ECC with a potassium of 3.1, I would always be concerned that he had dialysis disequilibrium. Now, I'm not saying that's what causes cardiac arrest, although I think it made his potential more likely, but it may actually be what has caused his primary neurologic symptoms, which is he got bystander CPR and he didn't wake up. He didn't wake up. Now, he's sort of waking up. I didn't see him today, but yesterday he was sort of waking up a bit. So that was fantastic. That was really lovely, starting to wake up. And lots of times with dialysis disequilibrium, your patient will look like he's had a total cerebral hemorrhage, a very significant stroke with usually bilateral deficits. Can't walk, can't move, can't think, can't talk, can't swallow. And if they're lucky, that's going to resolve in 4 to 6 to 12 or so hours. So what we're going to hope for, and we're not going to ever really know, was this also impacted by dialysis disequilibrium syndrome? I would certainly consider that it was, because of his electrolytes at time of presentation. Typically occurs during or immediately after dialysis. Big increase in brain water, big change in the pH of cerebral spinal fluid, and patients just can go straight into a coma, or they can have seizures and confusion. We don't really know. We don't really have any description of what happened, except that the patient had a cardiac arrest. Okay, so here's the thing is, if you have a coma during dialysis, you got to actually replace really quickly. And of course, one of the major things is hypoglycemia, but we already know that his glucose when he came into the ECC was 144. So he looked okay. Now, if he does survive, if he does go home, I'm going to give him, I say me, but I mean his provider, should give him instructions about his dialysis. His nephrologist should recognize that a longer session with a rapid flow is going to be very detrimental for him. He needs a longer time with a slower flow. So he might need a 4 to 6 hour run, slower flow, slower clearance, so that this doesn't happen to him again. So now I'm coming to the last part of my talk here, and I'm going to say thank you to Janine. Janine is a CVICU nurse who yesterday, when I was in the CVICU, called to my attention her concern about this particular patient. And I'm going to share a couple of things with you about this patient, okay? So I just want to remind you about those 3 actions: pace, capture, and sense, okay? Pace means that we're going to send a stimulus. Capture means that the chamber is going to respond. And sensing means that the pacemaker generator sees that the patient depolarized on his own and inhibits firing. Now, when Janine spoke to me, she was uncertain about what was happening with the pacemaker, and lots of colleagues, fantastic colleagues around, actually looked up and said, oh, look, he was on a DDDR and then he got switched to a VVI. Okay, so now we're just going to take a look at his EKG strip on the monitor, and you can see here's his ventricular spike, followed by capture, spike, followed by capture, spike, followed by capture, spike, followed by capture, and this is V pacing. Okay, so that was VVI. Okay, so now I want to look at, this is the same patient. I want you to look, this is his lead 2, and this is his V lead. So in his lead 2, you see the spike followed by capture, spike followed by capture, spike followed by capture, spike followed by capture, and spike followed by capture. But now you see this other spike, and you have a delay. Okay, so my perspective is, I got a lot of delay in that V lead. So the first thing I want to do is check his leads and make sure his leads are placed correctly, and they are. Okay, so then my next question is, am I seeing an atrial spike here and a ventricular spike here? I'm seeing the atrial spike here because the lead is closer to the atria and to where the atria is firing. And then I'm seeing the ventricular spike here. I don't have the answer. I don't have the answer. In either case, he's been programmed for VVI. So in either case, here's the thing. I don't want to get hung up. Is this the atrial pacer and is that the ventricular pacer? And am I seeing two different things? What I'm going to say is I need EP to look at this strip, because here I've got spike ventricular and spike with pause, spike with pause, spike with pause. Is that the atrial spike with an atrial capture? Or does this actually show me a failure to capture? I can't know that. I need EP to come and look. I can't tell you because I can't go in the room and make changes, because if this was a patient with a temporary pacemaker, I would increase the rate and I prolong the AV interval so that I could see what was actually happening. I can't do that because it's a permanent pacemaker. So I need EP to come and take a look at the strip. Okay. When we have abnormal pacing, so if we're just taking a look, we're going to look really at the ventricular non-capture. Okay. Here's a pacing spike that's not followed by ventricular capture. Spike to spike to spike to spike to spike. You have a spike that's fused in here. You have a spike that's basically here. This is the only one that actually has appropriate capture. So spike to spike 1, spike to spike 2, spike to spike 3, spike to spike 4. The spike to spike interval stays constant, but I don't have ventricular response. This is non-capture. Okay. Yesterday, this is what we're seeing when we're looking at our patient. What the heck is this? This is the adventure in pacing that I'm talking about. Here's your spike, here's your capture, here's your spike, here's your capture, here's your spike, here's your capture. Okay. Now, this might be a little spike here, I'm not certain. And there may be a spike here. I think you actually have fused your patient's own beat with pacing spike. Okay, not positive, but I'm looking at spike to spike intervals. So spike 1 to spike 2 is constant, spike 2 to spike 3 is constant, spike 3 to spike 4 is constant, but the patient now fires his own beat. This is a fusion beat. Here's your spike, but spike gets gobbled up by the patient's own electrical activation. And then you have a pause, and that pause is resetting the cadence from the patient's own beat to the next spike, which is fused in here. And now the patient has fusion beats. These are all fusion beats. Okay, this is a failure. There's a failure with your pacemaker. And then you have a pause, and then you fire your pacemaker again. So I'm looking at that pause, I'm looking at that fusion, and then I look, this is my lead 2. Now I look down here at my V lead. Okay. What is that? Okay, that really concerns me. So now I look at this, I say spike response, spike response, spike response. Okay, not sure, is that an atrial pacer? And is that atrial pacer still firing even though you reprogrammed it to VVI? I need EP. My patient needs EP, and I mean now, not tomorrow, not later. Talking to my APP, they say, don't worry about it. Okay, no, I'm really worried about it. I'm really worried about it. It may be totally harmless, but I only can rely on EP to tell me because I can't look at the pacemaker settings. So when I see this, okay, is that a ventricular fire and then followed by another ventricular fire with the pause? Is that an atrial fire and a ventricular pace? I don't know. I know that the pacemaker is supposed to be VVI. And during these periods, the patient drops his blood pressure. Each time this happens, and it happens pretty frequently during the day. So this is quite concerning. So I'm calling EP and I'm going to say in the V lead that I've made sure my V leads are in the right position. I'm having a delay between the spike and the capture. That's why I think down in the ECC, they were saying failure to capture. But I'm also having dual spikes, and it looks like I could have an atrial spike followed by a ventricular spike, and then that delay, but a ventricular capture. Is that delay normal or abnormal? And when I look up here, I see exactly the same visual, but my spike is followed by ventricular capture. So here's the thing. I can pretty much diagnose any failure with the temporary pacemaker, because if I can't do it from the EKG, I'm actually going to evaluate it. by manipulating the pacemaker settings. Now, you don't do that. Your APPs do that. Your doctors do it. I do it because I've been blessed to do it, but I never do it without speaking to the physician or APP in charge first. I don't just go in and manipulate people's pacers. But a lot of times APPs will say to me, well, I don't really know that much. Can you teach me? And so we'll go in the room and I say, here's what I'm going to test. So what I would do here is that I would go in, if I had a temporary pacemaker, I would turn the MA down on the atria to 0. I would turn the MA up, that's the amount of amplitude to capture the ventricle, and I would increase the rate. Because what I want to see is when I'm firing my pacemaker spike, do I have an immediate capture? It's very hard for me to say that my pacemaker is functional. I actually think this patient has pacemaker failure, and I think you have abnormal spikes. I think you have failure to sense. I think you have failure to capture. That's considered pacemaker failure. Because it's a permanent pacemaker, we can't do anything about it, except we are going to assure that our patient's electrolytes are stable. We are going to assure that we have tight limits on his monitoring. We're going to assure that we're going to capture EKG traces in 2 leads so that EP can look at what we've seen, because they may come to the bedside and they don't see any of this because it's happening intermittently. This is very concerning because this is an unstable patient with an unstable myocardium. And if they actually have failure to sense and or failure to capture, it may mean that our patient then will have complete pacemaker failure. So I, as the bedside nurse, number one, I'm going to be prepared to make sure that the electrolytes are stable, to be very aware of that now that the patient's now on CRT, that I must be aware of my electrolyte balancing, and that I've got to really pay attention to that. But it also means that I'm going to assure that every nurse who takes care of that patient knows how to operate transcutaneous pacing, because if his permanent pacemaker is failing, you're going to have to apply transcutaneous pacemaker until we can get downstairs to the EP lab. So electrolyte balancing, transcutaneous pacing, when you have obvious pacemaker failure. This is obvious pacemaker failure, but we're not sure what the failure is because we can't actually test it. And so I'm going to call EP. They may say, I'm not sure either. I'm going to have to test it. I'm positive they're going to say, here, you've got spike, fusion, spike, fusion, spike, fusion, spike, fusion, spike, fusion, spike, fusion, pause. And that's a failure here. This is a little bit of a failure. And then you have another spike. Okay. So this is really, really important. We cannot all be pacemaker experts. I study pacemakers all the time. Every time there's a pacemaker, I look at the strips, I evaluate the strips, I look at changes. We cannot all be experts. I am not an expert. I might be more expert than some people because I look at it all the time. And I've worked with pacemakers for, 3,000 years that I've been a nurse. But the best expert on pacing is the electrophysiologist. So when in doubt, have electrophysiology take a look. So this patient now is off of TTM. He's on CRT. And yesterday he was waking up. I'm hoping that I'll get to see him today. I hope so, after we finish our discussion. So that concludes today's Adventure in Pacing. And I want to thank you very much for attending with this really extraordinary case study. I'm going to stop recording and then come back so we can have some discussion.